3.2 mm clear temporal incision is made and 2 paracenteses incisions are made superiorly and inferiorly. Cohesive viscoelastic, Accucoat, is used to fill the anterior chamber. Accucoat is recommended since other viscoelastic agents may cause cataract formation when trapped between the ICL and the crystalline lens. It is important not to overfill the anterior chamber as it would make it harder to tuck the haptics. The ICL is already placed onto the platform of the cartridge, which is then closed and placed into the injector. Ready to inject to anterior chamber. ICL is slowly injected to anterior chamber, but there is some resistance during injection. Distal part of the ICL is trapped into corneal incision and surgeon tries to release the lens and unfold the disobedient lens. Finally, ICL unfolded upside down. Story begins. Surgeon tries to flip the lens in situ at anterior chamber, but the lens is intractable to flip completely. AC depth is just 3 mm and damage to corneal endothelium or crystalline lens is inevitable. The ICL haptic is grasped by toothed forceps and lens is explanated parallel to iris plane. Second attempt. The ICL is loaded into the cartridge again. This time surgeon tries to inject it into the anterior chamber very gently and slowly. Unfortunately, ICL unfolded incompletely this time and opens in upside down position again. The surgeon decides not to give up, using a forceps to grasp the ICL haptic near the wound and slowly nudge it out by pulling technique. The direction of explanation should be parallel to iris plane to avoid damage to capsule or endothelium. ICL was washed with balanced salt solution and loaded to cartridge again. Third attempt. For the third time, ICL injected to anterior chamber slowly and very under control. Well done. Finally, the intractable ICL is unfolded in proper position. More viscoelastic is injected anterior to the lens. The haptic footplates are then positioned under the iris. A manipulator aids in tucking the haptics of the ICL under the iris. Viscoelastic should be removed completely after conclusion of the case in order to reduce risk of intraocular pressure spike postoperatively. And finally, intracameral injection of diluted triamcinolone and myocol prior to ensuring a watertight incision.